Good morning, good afternoon, good evening, wherever you are. I welcome you to this webinar. Thank you for joining the Nutrition for Growth Summit side event on public-private partnerships to accelerate improving the nutrition of women and children through multiple micronutrient supplementation. We have many global opportunities to improve nutrition for all. For example, to mention some, we have the Nutrition for Growth Year of Action. We have the Decade of Action on Nutrition. In fact, we are still in the midst of this decade. Then the Decade of Action to achieve the Sustainable Development Goals. It's important to note that now we have the multiple micronutrient supplements on the WHO Essential Medicine list. Our discussion today is to raise awareness on multiple micronutrient supplements, how to prioritize and increase accessibility of these supplements within the health systems in low and middle income countries, and also to enhance collaboration between public and private partnerships in promoting multiple micronutrient supplementation. My name is Anna Lati, a professor of nutrition at the University of Ghana. I will be your moderator for this event. We have lined up for you some great speakers. You will hear from governments, academics, civil society, and private sector, and how these actors are working together on viable and scalable solutions to close the micronutrient gap, especially for maternal, newborn, and children. There will be a case study from the Philippines on multiple micronutrient supplementation, how it's being implemented. So the implementation, feasibility, and cost effectiveness. You will also hear from Tanzania, a representative from Tanzania. Our speakers will be happy to answer any questions you have. Please use the Q&A function to send your questions, and use the chat box to let us know where you are joining from. Now, to go straight to our program, I would like to introduce our first speaker, Dr. Saskia Ossendap, who is the Executive Director of the Micronutrient Forum. She will open the discussion with the global status of multiple micronutrient supplements. Saskia, the floor is yours.
Yes, thank you, Anna, and it's a delight to be here, and good morning, good afternoon, everyone. So it's a real pleasure to be here with you today in this session on multiple micronutrient supplementation for pregnant women. And as Anna already explained in this session, you will hear more about this evidence-based, cost-effective, safe, and affordable intervention, which has the potential to improve maternal nutrition and to reduce adverse pregnancy outcomes. But my first encounter with MMS dates back to the time when I was working and living in Bangladesh about 20 years ago. And at that time, I worked at the ICDDRB. And for those of you who don't know the institute, it's a large research institute in Dhaka. And we were designing at that time one of the first MMS effectiveness studies that was held, which was called the MiniMat study. Next slide, please. So we are now here 20 years later, 20 years of research, guidance, and implementation. Because in 1999, the WHO, UNICEF, and United Nations University workshop defined the composition of what was then called the UNIMAP, UN International Multiple Micronutrient Antenatal Preparation Formulation, and which was then subsequently studied in more than 20 trials that were published between 2003 and 2010, among which was the MiniMat study from Bangladesh. But the introduction of MMS in programs has only been slowly following the evidence base, as the recommendations for MMS have been made for specific contexts. The WHO has issued several recommendations for the use of MMS in specific contexts of emergencies, in patients with tuberculosis, and in the context of rigorous research. And last year, the WFP and UNICEF issued a recommendation for the use of MMS in the context of COVID-19 for maternal nutrition and health programs. Over the past few years, nutrition partners have started coming together in various platforms to take collective action. But it was not until 2019, following the second meta-analysis that was published, that a group of 11 partners committed to additional investments in the introduction of MMS in low and middle income countries. And this was the Healthy Mothers, Healthy Babies Accelerator. Next slide, please. So these 11 partners made commitments at the Gates Foundation's Goalkeepers event in September 2019 to invest around $50 million into reaching over 17.5 million pregnant women by the end of 2022. Now, building on this accelerator, Kirk Humanitarian had a vision to bring more nutrition actors together to accelerate collective action. And this vision and investments of 3 donors led to the launch of the Healthy Mothers, Healthy Babies Consortium early March this year. And the Micronutrient Forum is proud to host the secretariat of this consortium, which currently has around 80 members, both individuals and organizations. And this consortium supports work of its members in advocacy, knowledge brokering, convening, and consensus building. Next slide, please. So where are we now? What is the status of MMS 20 years later in November 2021? MMS is now being introduced in at least 19 countries, supported by implementation research. And for this, we are not counting the ad hoc distributions in humanitarian emergencies. MMS, and you heard Anna already alluding to that, has been included in the WHO Essential Medicine List, which was announced October this year. And this year has also seen an increased communications with a common voice and an amplification of advocacy activities for MMS. Global partners are making investments in building the capacity for local production of MMS. And we've seen an increased interest from national nutrition partners to explore whether the transition from iron folic acid to MMS would be appropriate and feasible in their specific context. And you will hear a few examples in the session today. So in this session, you will also hear some fantastic speakers that talk about the science, the cost effectiveness, the need for policy adaptations, and the specific country experiences. And I'm extremely pleased to see this surge of interest, activities, and investments now in maternal nutrition and in MMS in particular, because we can not break the vicious cycle of malnutrition, and in particular micronutrient malnutrition, if we continue to fail women nutrition. So we need action, and we need your action. Next slide. So I thank you for listening, and I wish you an excellent session. Thank you.
Well, thank you. Thank you very much, Saskia, for taking us through the roads from beginning to where we've got to so far. This is very exciting development around MMS. Thank you so much. Now, I'd like to go on to the next speaker, who is Dr. Emily Smith. She is with the Department of Global Health and Population at Harvard School of Public Health. She will present on the evidence base behind MMS using human capital tool. Emily, the floor is yours.
Thanks so much for having me. I'm thrilled to be here and tell you about the evidence as it's evolved. So background, you all know that WHO estimates that 5.4 million children died in 2017. And while the under 5 mortality rate has decreased by nearly 60% in the last 3 decades, our progress is not fast enough, as shown on the left. Compared to the average 2 to 4% annual reduction in child mortality that we actually saw in sub-Saharan Africa during the MDG era, that's what you see in green, substantial acceleration is needed to meet the 6 to 9% reduction per year required to attain the SDG targets by 2030. And that's what you see over here in the blue on the second map. Another issue is that causes and timing of child death are changing. On the right, you see neonatal mortality in orange. accounts for an increasing proportion of under 5 deaths from 2000 to 2015. In 2015, you can see that neonatal mortality increased to account for nearly 60% of child deaths in South and Southeast Asia. And half of that is due to prematurity in light orange here. And that's a big problem because we do not have many tools in our toolbox to address these causes of death. We track low birth weight as a proxy indicator for preterm birth. This map shows that the prevalence of low birth weight, as it's estimated by Hannah Blencow and colleagues in 2015. And one of the most alarming findings out of this work is that we're not making much progress in reducing low birth weight. From 2000 to 2015, the average annual rate of reduction in low birth weight was just over 1.2%. And we'll need to double or even triple that rate of progress to meet global goals. So what can we do about it? That's why we're here, right? Decades of research has shown that poor maternal nutrition, you can see that up here, is a major cause of babies being born too soon or too small. And research shows that maternal malnutrition tends to travel together. You see here in the bottom right, data from Nepal showing that women tend to be deficient in not a single micronutrient, but rather multiple micronutrients. And so 3 decades of research plus rigorous WHO guidelines that were recently updated provide one of the many solutions to really accelerate our progress in maternal and child nutrition. Antenatal multiple micronutrient supplements that include iron and folic acid are now recommended in the context of rigorous research by WHO. And this new guideline notes how important it is to do implementation research while you're scaling up a new program to make sure that the program is acceptable and equitable and effective. So let's be clear about what MMS is, and then I'll talk more about the data. But here, the MMS formulation developed in 1998 contains one daily dose of 15 vitamins and minerals, and that includes iron and folic acid. And this dosage is based on the requirements for pregnancy. So I like to call this a comprehensive prenatal vitamin. There are 2 different systematic reviews that summarize the last 3 decades of research here, and these inform the WHO updated guidelines recently. So I'll give you a quick summary of these 2 systematic reviews. Overall, the results are consistent between the 2 studies. Low birth weight, MMS reduces the risk of low birth weight by 12 to 14%. It also reduces the risk of being born too small or small for gestational age. And MMS reduces the risk of preterm birth by about 5 to 7% consistently across all of these studies, including over 100,000 women. Here you can also see some work that I did in collaboration with the international group of investigators who did all of these studies. And here you see, we asked the question, did any group benefit more from MMS, or even were there any groups that were potentially harmed from MMS? There's no need to read all of this, but relative risk less than 1 are highlighted in green. And what you can see is that all groups really benefit from MMS. And some groups benefit more, like women for anemic, for example, get a bigger benefit from low birth weight, but all groups really benefit. And overall, we see these larger gains for undernourished women and no harmful effects overall. The trials overall also suggest that MMS reduces the risk of stillbirth slightly by about 5 to 8%. And you can also see that we see benefits for neonatal mortality and infant mortality, specifically for female infants, which is probably related to the causes and timing of death that are a bit different between male and female babies. I often get questions about the side effects, and that's important to consider. And so my OB friends anecdotally always tell me that these supplements can cause stomach problems. But what we see here are data from the randomized trials of both iron and folic acid compared to placebo and on MMS. And although there's a bit limited research from the randomized trials, we really see that there's no impact on this long list of side effects. And so these stories we hear are probably about really the impact of pregnancy, which definitely does cause things like heartburn or constipation or nausea, but not the supplements. Another key piece of newer evidence is also work by Alison Yornand at Penn State that came out, and she summarized the potential risk of exceeding the upper limit if in a hypothetical world, a pregnant woman is taking a well-fortified, good diet and the multiple micronutrient supplement. And when assuming this high dietary intake plus a standard amount that's in a multiple micronutrient, only niacin and iron would be expected to be reaching the level around the upper limit. And there's no real concerns about the safety of this. And so that's good news. There's no need to worry really about excess intake when we're giving these supplements. And the last piece of new evidence here is from Nandita Parimal and Chris Sudfeld at Harvard that looked at what would happen if we're able to scale up MMS to about 90% coverage. They find that we would gain big yields in educational attainment for kids, about 5 million school years. That's this map up here. You can see the gains are bigger in South Asia, across some parts of sub-Saharan Africa and South America. And that increased educational attainment could translate in up to $18 billion in lifetime income. So overall, the evidence is quite clear. I do a lot of this type of evidence synthesis. It's not always so simple. There's not always so much data, but here we have many high quality randomized trials that show that daily supplementation with MMS compared to iron and folic alone improves birth outcomes, including a 12 to 14% reduction in low birth weight, reduction in being born small for gestational age, and in preterm birth. We also see from this new data benefits in reducing mortality, especially among female infants. And all women are found to benefit. Undernourished women benefit more, yes, but all women benefit from these comprehensive prenatal vitamins. And this ultimately translates to better educational achievement and a potential $18 billion in lifetime earning for these kids going forward. And so all of this is to say is that the evidence is clear that MMS is superior to IFA alone in supporting a positive pregnancy experience and a healthy infant who not only survives but thrives going into childhood. So that's my summary of the evidence. Look forward to talking with you all more about it. Thank you.
Yes, thank you very much, Emily, for presenting the evidence. From what you have just presented, the evidence is clear. Your bottom line in your presentation was that MMS is superior to IFA alone. Thank you. I'll now go to our next presenter, who is Dr. Klaus Kramer. He is the Managing Director of Sight and Life Foundation. It's an innovation think tank working on elimination of malnutrition. He will present on policy updates and recommendations for scaling up MMS solutions. Klaus, the floor is yours.
Thank you so much, Dr. Lati, for your very kind introduction. I'm very pleased to be here today and being part of the session, and will share with you insights on country readiness and the role of the essential medicines list, as we have heard already, for scaling up multiple micronutrient supplements. The next slide, please. As we have heard from other presenters, maternal malnutrition is an urgent problem. It's among other conditions associated with underweight, anemia, and low birth weight, which are also much more common in low and middle income countries, where access to and affordability of diets dense in vitamins and minerals ever remains limited. And the lack of micronutrients can lead to serious and irreversible delays in children's growth, learning, and future economic prospects. For example, the World Bank's analysis found that children who were well nourished during their early years were likely to earn 20% more than their malnourished peers. And improved nutrition has, as we also just heard from Dr. Emily Smith, the potential to make profound effects on human capital development. We also have heard much progress has been made in the supply and uptake of multiple micronutrient supplements, or MMS. And it's, in my opinion, one crucial component for improved nutrition, health, and survival of mothers and their babies. And at Certain Life, where I'm working, we aim to keep this momentum going by supporting the scaling up of multiple micronutrients. In order to translate this evidence, the next slide, please, in support of multiple micronutrient supplements in pregnancy, we need global and country-level action. To explore the introduction and scale-up of MMS, this entails further research to facilitate the implementation in supplementation programs. The recent addition of the UNIMAP MMS formulation to the World Health Organization's model list of essential medicines, also known as EML, complements the 2020 WHO conditional recommendation for MMS in the context of implementation research. And we have heard already, it has taken us more than 2 decades collecting evidence, compiling evidence to the level before the World Health Organization started to make at least a conditional recommendation. And with the appearance of MMS on the essential medicine list, the introduction and implementation of programs will be facilitated. But what does it really mean for countries to have MMS on the essential medicine list? So the registration of, last slide please, the registration of MMS on the WHO's essential medicine list is an important step, but we need to do more for the scale up of MMS. But it will facilitate its procurement, supply, and use. And at the national level, we expect that the inclusion of MMS on WHO's EML encourages local decision makers to explore the introduction of MMS and include it in their national essential medicine lists and policies, which can then in turn result in increased accessibility, lower the cost of MMS, and fewer restrictions on importing or in-country MMS production. Inclusion in the national EMLs will also help facilitate the smooth integration of MMS into health systems and support the delivery of MMS to the most vulnerable mothers. And ultimately, it will support the achievement of global and national targets like the Sustainable Development Goals 2, Zero Hunger, and 3, Good Health. And of course, the World Health Assembly nutrition targets. Next slide, please. At Certain Life, we have experienced several first-hand challenges in delivering MMS at scale, which are quite similar to the many challenges of iron and folic acid supplementation programs. But from our research and experience with MMS in Bangladesh and other countries, we have identified key opportunities to advance MMS scale up in the current nutrition environment. Some of them include opportunities to address evidence gaps and develop key insights on how to deliver MMS effectively across different contexts. But the important potential for addition of MMS to the EML to motivate country governments to explore the feasibility and acceptability of introducing MMS in the context of implementation research is and should be aligned with the WHO guidance. And in fact, several national governments in Africa, Asia, and Latin America, and the Caribbean are already moving to introduce MMS by applying systematic implementation research, which Certain Life has actively supported. The next slide, please. Certain Life is supporting countries with their MMS work in multiple realms. This reaches from global policy and advocacy to supply readiness. Here on this slide are just a few examples. One of it is the special report on focusing on MMS in pregnancy, published last year, and the second report will be prepared for next year. And we have worked on supply and demand in countries such as Bangladesh, Haiti, Ethiopia and others. And we are also actively involved in global activities around advocacy for MMS. Next slide, please. The next slide shows an example from our consumer research study in Bangladesh on the packaging design to develop a market-based model for MMS through pharmacies. Apart from evaluating the overall appeal of the packaging, we wanted to check for validation regarding specific elements such as the product name, full care, tagline, color, image, and the of the pregnant women on the packaging. And in in-depth interviews and focus group discussion, we could uncover unexpected insights. For instance, one woman said, looking at the logo, that it would be easy for her husband to identify the product at the pharmacy. This told us that it isn't always the woman who buys the MMS product. And the consumer reactions also helped us to gauge which packaging elements needed to be improved or removed or retained. And it eventually resonated with the target audience to ultimately support the development and launch of the MMS product Full Care through SMC pharmacies. Cyton Life, the next slide please, also works intensively on the supply side of MMS. Over the past 3 years, we have developed a national level framework to assess the market and production landscape for MMS. This framework can also apply to the evaluation of health policies and partnerships, which can be harnessed to build consensus and increase momentum for policy changes in support of MMS supplementation. After deploying this framework, one can categorize the country in one of the 3 production scenarios as shown here, with a sizable industry, nascent industry, and no viable industry for local production of MMS. And informed by supply readiness assessment done in 4 countries with UNICEF, we are developing a comprehensive toolkit to enable anyone planning to conduct such an assessment in any country. Over the last a few years, we have also conducted this assessment in more than 20 countries funded by multiple donors. Next slide, please. The last one. So now that MMS is on the WHO EML, what can we do to support countries? The number of countries interested in introducing MMS is significant, and it's growing, as Dr. Ossendorp mentioned. And support is needed to strengthen the enabling environment in these countries, ensuring that the introduction of MMS does not only meet immediate needs, but it's also institutionalized to ensure effective and sustainable scale-up. There are a few key actions that we as a nutrition community can support to join countries in the MMS journey. They include, for instance, the introduction of MMS as part of implementation research, supporting the country to include MMS in the country level essential medicine list. And the WHO has got guidelines for countries to develop their own essential medicine list. And strengthening the policy and fiscal space for MMS, such as including it in antenatal care and nutrition policies and guidelines, and committing resources to ensure program sustainability. MMS, as we have heard several times, is a proven solution with immense potential for health and economic gains. Its introduction is, in my opinion, a moral imperative, and we must really act now to take it to scale. Thank you.
Yes, thank you very much, Klaus, for taking us through, the policy recommendations and really how countries can prepare themselves to take up, implementation of MMS. This is really useful. I think in the next sessions, we will now go into what countries can do. So we are looking at countries at this level. So I'd like to introduce Kaleneth Fernandez San Valentin, who is the Health and Nutrition Technical Manager for World Vision in Philippines. And she's going to present on the need for public-private partnerships in this space. So, Nath, the floor is yours.
Thank you, Dr. Anna. for the introduction. Good morning, good afternoon, and a pleasant day to everyone. It is an honor for me to be able to share about the need for public-private partnership for increasing the priority and accessibility to multiple micronutrient supplements. I will be sharing with you the efforts of the joining forces for last mile nutrition here in the Philippines. Next slide, please. World Vision, Royal DSM, and Sight and Life Foundation have come together to forge a partnership known as the Joining Forces for Last Mile Nutrition. The collaboration exists to develop sustainable solutions that will improve availability, access, affordability, and the aspiration for nutritious food, with a specific focus on the first 1,000 days to reduce the prevalence of stunting. Here in the Philippines, much still needs to be done in addressing the gaps on maternal nutrition, particularly in lowering the proportion of nutritionally at-risk pregnant women and iron deficiency anemia, which persists as a problem of public health significance among Filipino women. The Royal DSM, Sight and Life, and World Vision Partnership, of course, in collaboration with the Philippine government, will bring in resources and expertise in providing durable and effective solutions in addressing the limitations to availability and access to multiple micronutrient supplements. Next slide, please. The project uses a three-pronged approach. First, increasing access to MMS. Second, adequate demand and use of MMS, as well as encouraging future policy reform to shift from iron and folic acid supplementation to MMS for pregnant and lactating women. The pilot targets 80,000 pregnant and lactating women in 4 provinces with 4 municipalities. And we will be focusing on transforming the MMS value chain from end to end, while we continue to fine-tune an MMS operating model that is viable, repeatable, and scalable. Next slide, please. We see that it is necessary to consider the comprehensive requirements between demand and supply and how these are supported by existing policies in the country. Both sides of the supply chain require policy-level support. Formative research on the perception of women, on the use of MMS, and barriers to compliance will inform how approaches to making MMS more accessible can be improved. This program will work with doers as well as community health workers to communicate desired behaviors, particularly on adherence to MMS. The behavior change component of the demand creation will start with assuring a user-centric approach to promotion. Next slide, please. Creating demand is an important variable in the equation. However, the need to increase supply is necessary in sustaining demand. Localization of supply would be a game changer for maximizing the demand. A reliable, high quality and standard compliant, cost-effective and cost-efficient source of MMS is a need articulated at various tiers of the government here in the country. As this current gap is addressed, evidence is also needed to support local, in-country procurement and production of MMS. While we sensitize pregnant and lactating women on the use of MMS, we will equally need to sensitize and train health workers at every level on MMS use and promotion to ensure their competence and championship. And it really needs to be in place. The product shift from IFA to MMS shouldn't be underestimated in the current health system culture. Preventing stock out and assuring product quality are also key factors in building demand. The new product-specific protocols pertaining to quality, safety, and management need to be clearly established and requisite competencies in alignment built at each stage of the supply. From the perspective of universal health coverage, the MMS product must be assured quality, be affordable, and available. Next slide, please. From the country-specific context, it is important that the policy environment is continued to be referred to as the backbone for demand and supply. The national policies are enablers for action. When we designed the project, we had in mind the desire to strengthen the national policies, one of which is Republic Act 11148, or the Health and Nutrition of Mothers and their Children's Act, which was mandated to institutionalize efforts and resources in an integrated manner by all branches of government using a whole of government approach in collaboration with civil society organizations and the private sector. One of the focus areas of the Act is to improve the quality and quantity of diet and adequate intake of necessary nutrients that address maternal and fetal nutritional needs. Working closely with the Department of Health, the National Nutrition Council, and relevant national government agency, the partnership will continue to align its efforts to center on providing technical support in the amendment or even improvement of national policy on micronutrient supplementation. So in closing, ensuring quality along the value chain is important. As we continue to collaborate, we address gaps in technical capacity, and we become deliberate in aligning our efforts to strengthening policies on MMS or achieve coherence between policies, manufacture of low-cost MMS, and finding ways to incentivize local production are the next steps to enhance and strengthen the value chain. So this is the end of my presentation. Thank you very much for listening.
Yes, indeed. Thank you very much, Kalineth, for taking us through the process in refining the value chain for MMS. I think that clearly we've seen the importance of public-private partnerships in doing this. Very grateful. Now I would like to go on to the next presenter, Dr. Azucena Daranginya from the National Nutrition Council of the Philippines. And she's going to speak to us on the situation on implementation of MMS in the Philippines. Basically, the needed transition from iron folic acid to multiple micronutrient supplement.
Good day to all our distinguished guests and colleagues. First of all, I would like to thank the organizers for inviting the National Nutrition Council Philippines to this event. I will briefly present the initiatives done by the NNC through its Tutok Kainan, or the Directly Observed Supplementation Feeding Program, which can contribute to creating an enabling environment for the transition from iron folic acid, or IFA, to multiple micronutrient supplements, or MMS, to reduce the rate of maternal anemia. Micronutrient deficiencies have considerable impact on economic productivity, growth, and national development. Several studies have suggested that the introduction and scale-up of MMS as part of maternal nutrition programming is an opportunity to improve pregnancy outcomes and accelerate progress towards the several Sustainable Development Goals and World Health Assembly Global Nutrition Targets 2025. In 2020, the Philippines launched the Nutritional Guidelines for Women of Reproductive Age. These comprehensive guidelines targets pregnant and non-pregnant women and includes micronutrient supplementation such as MMS during pregnancy as one of the key interventions. The Nutritional Guidelines for Women of Reproductive Age is actually currently being rolled out, and evidences are being generated for national scale-up. Implementation research is also being conducted in partnership with UNICEF to determine, one, whether a maternal nutrition package with MMS will result in improvements in compliance with micronutrient supplementation intake, coverage of maternal services, as well as micronutrient status. And second, capacity and readiness of the local government units as regards to governance, financing, service delivery, information systems, health workforce, and supply chain management of MMS and other commodities needed to comprehensively implement the maternal nutrition guidelines. To support the implementation of the National Dietary Supplementation Program, considering the COVID-19 pandemic, and to operationalize the first 1,000 days law, the National Nutrition Council conceptualized the dietary supplementation in the first 1,000 days initiative to help in the reduction of child stunting and wasting. The program is dubbed as Tutok Kainan to underscore the need to closely monitor the nutrition of the target beneficiary during the crucial period of the first 1,000 days to prevent low birth weight and stunting. Tutok Kainan aims to contribute to the prevention of stunting by improving the quality and quantity of food and nutrient intakes and utilization of related ECCD F1K services among the nutritionally at-risk pregnant women and children 6 to 23 months old in the target program areas. The National Nutrition Council, through its Tutok Kainan, which components include micronutrient supplementation, is creating an enabling environment for the introduction, implementation, and scale-up of multiple micronutrient supplementation through the following. First, the Tutok Kainan Supplementation Program is engaging in advocacy activities for the prevention of micronutrient deficiencies during its social preparation activities with all local government units as pilot areas. It is important for governments to receive credible science-led data on micronutrient supplementation and have access to the right tools to translate and disseminate the information to increase adherence to micronutrient supplementation programs and support positive results. Second, the Tutok Kainan Supplementation Program contributes to the identification of possible MMS beneficiaries as it already has an existing database of pregnant women in its Tutok Kainan reporting system. The existing Tutok Kainan database may also serve as a reliable data which can be used to improve systems for forecasting and procurement, as well as supply chain management, capacity building for health managers and service providers, and strengthening government systems for policy, planning, budgeting, and coordinated implementation, as well as joint monitoring and evaluation. Third, the Tutok Kainan Supplementation Program, through its nutrition education component, has also contributed to educating women on the importance of micronutrient supplementation and nutritious diet in pregnancy. Transitioning to MMS requires attention to social behavior change communications, which are tailored to the specific needs of pregnant women and key influencers on the importance of nutritious diets, including the routine use of micronutrient supplements. Tutok Kainan is already doing this through Nutri-text messages, in which target beneficiaries are receiving updates, messages, or key nutrition messages that encourage the targets to adopt positive behaviors, and actions on nutrition, prenatal and postpartum checkups, water and sanitation and hygiene, responsible parenthood, and other ECCD-related messages. Although the Tutok Kainan Supplementation Program has already initiated efforts which can contribute to the transition from IFA to MMS, MMS for pregnant, although recommended, is not yet part of the routine National Micronutrient Supplementation Program of the Department of Health due to the ongoing implementation research. There are also several challenges and considerations in transitioning from IFA to MMS. First, MMS costs more than the IFA, but based on the cost effectiveness tool by Nutrition International, the transition is very cost effective compared to the WHO threshold and as a high return on investment. The long-term economic benefits of transitioning outweigh the cost in the order of hundreds of times. The second challenge is on equity. MMS should be made available to all pregnant women, especially those that are marginalized. The implementation of the Universal Healthcare Law and the Mandanas-Garcia ruling, which will provide increased internal revenue allotments to LGUs or local government units, may help address issues on equity. The third challenge is on acceptability. Acceptability of MMS is still to be determined through the ongoing operational research. And lastly, on feasibility. MMS supplies in the country is sourced outside the country by NGOs or UN organizations, but not yet commercially available in the Philippines. Such a commitment to introduce MMS holds the promise of accelerating a country and global level progress towards the prevention of maternal anemia, improved birth outcomes, and the achievement of the related SDG targets. With modest amounts of money and a stronger political and technical leadership, we can get the job done and equitably improve the health of millions of pregnant women and their babies. Thank you very much.
Thank you so much, Azikuna, for highlighting the transition, the challenges, and also the considerations that must be looked into in actually transitioning from IFA to MMS. This is very useful, and I'm sure that the countries who are on this platform have learned a lot from you. Ladies and gentlemen, we'll now go on to our panel discussion. We have lined up for you an impressive group of speakers, and these are specialists in their field. I'd like to introduce them now. We have Dr. Mandana Arabi, who is a Vice President at Nutrition International. We also have Romel Fuete, who is the National Director of World Vision Philippines. Then, thank you. Then we have Lutfred Peter Inelli, who is a Senior Research Scientist, Tanzania Food and Nutrition Center. And then we have Foko Vientis, who is the Vice President, Partnerships and Programs at Royal DSM. Ladies and gentlemen, these are panelists, and we have some questions for them to address, which will really throw more light on this whole discussions we are having. Our first question will be, and this I will address to Mr. Nelly. What do you think is needed to transition from IFA to MMS? What do you see as some of the challenges countries may face in the transition? And here we want to hear your perspective from the Africa side. Thank you.
Yeah, thank you for this opportunity. Yeah, as we have heard from the various presentations since the beginning, the way they have seen more evidence for the need to transition from the iron and the folic acid now into multiple micronutrient supplements, taking the evidence of the relative risk reduced by MMS in terms of low birth weight and also preterm delivery, and also the gestational age, birth size, and also we have seen some new evidence in terms of reduction of mortality, especially for neonates, the female neonates. So those are the very strong reason for transitioning. But again, everything is not going to move on smoothly without the challenges. So I can see some of the challenges which are facing us in terms of achieving this transition is that we have the global evidence is very clear, and even the WHO have already included multiple micronutrient supplements in the essential drug list because of those evidences. But we need to generate more evidence for implementational challenges which are locally different from one country and another. So, for example, some of us have been earmarking some critical micronutrient deficiency as the iron deficiency and also iodine deficiency. But you can see the micronutrient multiple micronutrient supplements have more than those traditional micronutrients which we are being addressing. So we need to know the biomarkers, the status for this other micronutrient. And also, after having the implementational research to gain the relevant evidence, the challenge of advocacy to achieve buy-in by the government and also some key stakeholders so that they can accept and endorse the inclusion of MMS into their essential drug list. And this will need also capacity development of the frontline actors so that they know what are there. So the rollout challenge, including the social marketing space, we have also technological space in terms of research, implementation stage, research, and also the knowledge space, capacity building. So these are the key enablers for transitioning. And after that, we have to deal with the issue of supply chain management issues, promotion and social mobilization to enhance acceptability among stakeholders. And one of the issue in the supply chain management issues, now countries need now to invest with the public-private partnership to invest in local technologies for manufacturing the MMS in their local countries. I think that will be more acceptable for them. Thank you.
Thank you very much, Mr. Nelly. I think you've highlighted the challenges that many similar African countries may also encounter, similar challenges as you have mentioned, but I'm sure there are solutions as we have seen. And any contributions from other members of the panel at any point will be welcome. I would like to move on. I'll be looking at.
May I maybe add?
Yes, please.
One short statement here. I think it's very important that we've heard now so much about the evidence. It's so clear. It's so it's really time to move. But for me, and I heard that also, for instance, coming back in the work that Klaus presented, we have to put the woman at the center, and we reach her either through a social safety net or through the market. In both cases, we need to win her heart and her mind to change. And I think that is something that we need to keep very close to our mind. Actually, we should have had a woman in this panel, a pregnant woman in this panel, and to have her speak her mind on why she would do this. That's so back to you.
That's fantastic. Great. Yeah. I would like, please, if anything, you can just raise hand and I'll see it. Now, I'd like to go on to the second question because of time. And the second question is, what role does cost effectiveness play in increasing the availability of MMS? And I'd like Mandana to please take this. And then, of course, the other panel members can chip in. What role? Thank you very much.
Thank you very much, and important question for sure. It's really great to be participating in this panel and discussing the MMS scaling up. I think, of course, we know that providing even iron folate acid supplements in many countries in larger scale and as part of the health system has been challenging. So, the issue of kind of convincing the governments to see this as a very, important decision, something that really is beneficial, as it was noted, something that's the right of women, it needs also some good rigorous methodology so that we can calculate all the incremental benefits, as well as the costs associated to transitioning from the IFA to MMS. What we know is that the benefits expand. There are more benefits linked to MMS, so that's important. And then the costing needs to be used and done in a way that the methodology brings the different dimensions and the different benefits together. So one of the ways to do this has actually been through a tool that Nutrition International has developed. And in this tool allows you to actually construct and test different scenarios, which includes up to 8 health outcomes for the MMS. You can choose the country, and again, you can choose the different scenarios where you can decide on the time span and the percentage coverage that you want to achieve, and then see what would be the cost effectiveness analysis results that come out. It will show you the aggregated benefits in terms of disability adjusted life years that are going to be saved, and then the cost per days that could be averted. And in most of these analyses, when you run this, you really come up with great numbers that shows the benefit cost ratio is something that's quite impressive. And that could be a tool that can be used for advocacy and for convincing the decision makers to move forward, based on the good results of these analyses. And the tool is available and is open access.
Well, this is very useful information that countries must know, because the implementers, those who are actually implementing these policies will need to convince, the policymakers to pick this up. And this tool certainly will be very useful. I'm very happy you brought this up, and hopefully we'll get more questions from member countries on this platform to ask more about the tool and how they can access it. Thank you very much. Any question? I see a hand from Romel, please.
Yes, Anna, I just want to add to what Mandana said. It's great that we have a tool for a cost effectiveness study. That's really great. And I really think that aside from that, it has the cost effectiveness study has to be done at the local, at the country level, because like in the case of the Philippines, as mentioned by Dr. Dayang Hirang earlier of the National Nutrition Council, there's more localization, there's more funding, more budget at the front, at the local level. So it would make sense to them if the study would be more localized, but great that we have the tool already, so that would be very useful, accessible at the country level.
Yeah, great. Thank you very much for really
making this. And if I may, Anna, actually to add a little bit, because I think it's important, the country context that came up, and I should have mentioned this. One thing that can be added to the tool is also the programmatic cost of the transition. And that's something that as we are exploring in different countries, we can add that. And the unit costs, which, we have something that's general based on what we have currently available, but that's something that with the economy of a scale and with local production capabilities could be changed. So again, I think that we are in a way still experimenting and bringing new additional data to be able to make this decision, but definitely adding those local information, contextual information to the analysis is important. Thank you.
That's great. That's great. I see certainly countries will be interested in this too. So whatever you can do to make sure that countries have availability and can use it, please, let's do it. Thank you so much. I'd like to go on to our third question. How can we best collaborate to accelerate and scale the solutions and impact of MMS? And Foko, I would like you to lead on this question, and then the others may add on.
All right, thank you very much. And listening to everybody on this, I mean, there's so much knowledge, there's so much evidence, it's unbelievable. I'm very happy that we have this group of people together, because you can hear it's now, I mean, we have the evidence, it's now a will of getting it done. And the distribution challenge that comes with it. Now, SDG 17 was not invented without a reason. It has a very good reason to be one of the SDGs, because systems change don't happen in silos. So it is all about collaboration. And collaboration and successful public-private partnerships are very much around complementary competencies. I'm good at something, somebody else is good at something else. If we bring it together, then all of a sudden it ticks and it works. And that's also what we have to do here. So successful partnerships is, as I said, complementary competencies, a shared vision, and everybody, of course, keeps their own accountability for the results. And if we look at that, and we work, for instance, Rommel was already mentioning, and we heard the case explained by Carlineth about the Philippines. DSM and World Vision teamed up to bring MMS to people. We call that joint forces for last mile distribution. DSM knows a lot about nutrition. World Vision reaches people. And if you bring that together, then of course, all of a sudden you're going to get traction. So that's how we need to move forward. Collaborate, go beyond your own self and look for the things that are missing to get the result. Why are we not scaling? That's the question that we need to ask ourselves. And that's the question where we look then for the partners. We partner with World Food Programme, with UNICEF, with World Vision. And we are now, through these partnerships, are reaching 40, 50 million people with improved nutrition. That's the sort of scale that we need, and it needs to be even bigger. And so I would certainly invite everybody to think beyond your own boundaries and look for partners and build trust, because trust is a key element in public-private collaboration.
Yeah. Great, thank you very much. I'm looking out for any hands up. Okay, Rommel, please, I give you the floor.
Yeah, aside from what Foku said, the Joining Forces actually project for last mile nutrition, the partnership of DSM, World Vision, and Sight and Light. This is really a great example actually on collaboration. But in the Philippines, just want to share this to our audience now, that we've had a 28 years of CSO partnership in the Philippines by the Philippine Coalition of Advocates for Nutrition Security, or PhilCan. So that has actually helped move and address issues and concerns on malnutrition in the country. And you also recently we've had our Scaling Up for Nutrition Civil Society Alliance in the Philippines, which also interacts with the government, UN organizations, academia, and donors. And if you, as you've heard from the NNC, National Nutrition Council earlier, they exemplifies a collaborative approach in addressing nutrition issue in the country, which means more engagement, representation of the civil society in finding solutions and in planning, as also mandated by law. So I think these are breakthroughs that we are experiencing and good examples in countries and very local context, which I hope other countries can learn as well. Thanks, Anna.
Yeah, thank you very much, Rommel, for that contribution. Very great, very important. Now, I would like to kind of bring the panel discussion to a close, but I will not let you off easily. Please give me in a very short statement. I'm going to ask you this question, and this is an elevator pitch, so you don't have much time. Just short, what you would say. What is the most important element needed to increase the priority and accessibility of MMS? Your minister wants you to just say this short statement and move on. How are you going to convince him? Okay, let me just start. Should I start with Mandana, please?
Sure, I can go first. Anna, I actually think at this point, the important thing is to see this as a path to scale and a transition phase at the global level. What's needed, and also a per WHO recommendation, is countries should consider this in the context of rigorous research. The specifics of that still need to be decided on. I think that it doesn't mean, years and years of studies, but it needs to look at, a good look at the systems issues and the public health system issues, and looking at some of the problems, even again, that already existed, even with iron folate. What we are doing, for example, now in Pakistan is to actually come together with the government and the different entities involved in the maternal nutrition space to identify the research questions, to come together and address those, and then prepare the country for making a decision on the transition. And in this process, I think it serves two purposes. One is research, and it provides the information for those decisions, but also it brings the right actors together so that they understand better and they really have a lot lot more buy-in of the process. So I actually think that has to be really inclusive in developing those research priorities and getting the buy-in together with conducting the research so that we are able and ready to help the country with those transitions within a reasonable amount of time.
Thank you very much, but the minister has just moved out of the elevator. Okay. Okay, now I'd like to ask Romel, short, brief, to the point.
All right, collaboration is the key element to increase priority and accessibility of MMS. It has to be a whole of nation approach. We can if the whole world, nation, and communities move. Thank you, Mr. Ambassador. I hope that helps.
And thank you so much. Now I'll go to Mr. Nelly. Mr. Nelly, your elevator pitch.
Okay, thank you. For me, I think we needed to advocate for this so that we can buy in from the governments and also key stakeholders. This should go hand in hand with the social mobilization so that to address all the myth, misconception, and the hearsays surrounding MMS, and also to facilitate the public-private partnership system transitioning. I think that will help in supply chain management. Thank you.
You're welcome. Foko, I give you the floor.
I would have two messages here. One is the fear of the unknown. First time that you ride your bike, it's very scary, but the rest of your life, you know how to ride a bike. So what I would say to the minister is, let's give it a try. Let's get on the bike and let's ride that first ride, because from then on, we know how to ride for the rest of our lives. That would be one. And the second is, and that refers back to what Klaus Kramer from Sight and Life, rightfully with all their great work already has proven so many times, is we need to get beyond social safety nets. And that means, as I said before, we need to win the hearts and the minds of mothers. And that means we need to increase MMS attractiveness and availability for consumers.
Okay, great. Thank you very much. Thank you all panelists and for all these great responses you have given. I'm sure our audience are eager to ask questions. Some have put some questions on the platform already. I will read some of the questions briefly. This question was mainly for Emily, that MMS reduces risk of mortality among female infants. Why? There's also whether there's MMS specifically for children. We've talked about MMS for women. Is there MMS for children? Then also, what is the feasible timeline for countries to adopt MMS? And then also, are women likely to take MMS versus IFA? Okay, and how do we get MMS adoption to be adopted faster? So these are some of the questions that have come. I'm going to open the floor to the speakers and the panelists. Just address some of the questions I've mentioned. There are more on the platform. Please look at it, and then we will take them up. So the floor is open for questions, please. Do we have one specific for children? We are talking about MMS for mothers.
Anna, hi, this is Saskia. I've answered that question in the chat, and yes, there is
fantastic.
There is not. It's not called MMS, but there is a guidance for multiple micronutrient powders for children, also for children to 12 years of age. So there's one for children 6 to 23 months of age, and then there's one for children 2 to 12 years of age. And I've given the link in the Q&A chat to that document.
Okay, that's great. The floor is still open. Just show your hand and please take the floor and answer some of the questions you see in the chat.
Yeah, on the question on what's the advice to the public and private players, I think I just already answered that. Get on the bike and try it to public and to the private players, is make this now an attractive proposition for consumers, and including also low and mid-income consumers. So that means look for the right channels to get there. That not only maybe pharmacies, but let's experiment beyond that to make the availability as large as possible. And that also ties into the last question that I see. Are there links between MMS and other nutrition interventions? We should and could use that, because in the end, it's creating awareness for the need for micronutrients that will lead to both large-scale food fortification interventions and MMS. So I think we should be exploring that more, is how do we make that a compelling and understandable proposition for beneficiaries of social safety nets and consumers. Back to you.
Okay, thank you very much. There's a question here, and Saskia, I'd like you to take this. What are some of the challenges to MMS implementation from the demand perspective? Are women more likely to take MMS versus IFA?
Yeah, so from research, we know that there's no difference in the acceptability of MMS versus IFA. So I wouldn't say that women are more likely to take MMS versus IFA. I think what we've heard also in the panel discussion is that this is an important question to tackle in programs and also in implementation research. Is in general, how can we create demand for women to take micronutrient supplements during pregnancy? And I think Foucault mentions very nicely to put women at the center. And I agree. I think it's important that we start to think about what's in it for the women. And we know, of course, we have the evidence, but how can we translate that in such a way that it is appealing for women? We shouldn't fool ourselves. We've had tremendous challenges with IFA over the last 30, 40 years. And there's, in general, very poor adherence. And I think that has to do with a lot of different factors, among which are the side effects. I think it's good to acknowledge or to mention that MMS have a lower amount of iron, which can cause some of these side effects. But it's also, I think, good to see this as an opportunity to invest in better programs that take this demand question into account. I see that Klaus has his hands up, and maybe he can share some lessons learned from the implementation research that have been ongoing.
Yes, please, Klaus.
Yeah, there has been a significant body of evidence collected on the demand generation for MMS and other products that are improving nutrition. And for MMS specifically, there is the need to do formative consumer insight research and not just exchange iron and folic acid programs by MMS. And many IFA programs just don't work due to a lack of supply, and the product is not adequately explained and promoted to the women, or it's just provided in a brown paper bag or wrapped into a newspaper, old newspaper, which is not attractive for women. A woman in Europe or in the US would never buy a product that is delivered in that way. So we must make these products aspirational, and also find approaches to simply remind women to take the supplement when it's in the house. There's work in India showing that women are closing the door at night and putting just a sticker on the front door, reminding women to take a supplement before they go to bed. So there are simple solutions, but we need to find them through thorough implementation research.
Okay, there are a lot of interesting questions on the platform. Unfortunately, time will not allow us to take them, but I'm sure that at some point, all these questions can be answered by the organizers. They are very interesting questions, but for example, what timeline do we have for countries to take up this intervention? But thank you all very much for your contribution. The panelists, I thank you. I think now I would like to move on. We are very happy and very honored to have with us the Assistant Director General for Universal Health Coverage and Healthier Populations from WHO, and the current chair of UN Nutrition, in the person of Dr. Naoko Yamamoto. It's a pleasure to have you on this platform. Please, the floor is yours as you give us the closing message, and of course your insights on what we have talked about so far.
Thank you very much. Thank you, Dr. Latry. And also many thanks for the Site and Life, World Vision, and DSM for organizing this event and inviting me. And thank you very much, audience. So first of all, I should say that today's evidence and discussion based on the many years work with the women, pregnant women, the families, and also, of course, academia and government, private sector, and all other partners. I really respect the efforts. And let me clearly say that adequate provision of the nutrients since early stage is critical to ensure good physical and mental development as well as long-term health. Excuse me. But today we see that globally there is a large burden of nutrition-related morbidity and mortality from conception through the first 2 years of life. So stunting, wasting, overweight, and obesity, maternal anemia, and low birth weight is a 5 big global target to address. So, but let me reiterate that most important thing is we should achieve this goal through healthy, balanced diet as a part of the healthy lifestyle. This is the fundamental issues. But yes, we know that not all diets are optimal at all times. That is why interventions such as food fortification or provision of the micronutrients, supplement, and other issues is needed. But the WHO has a clear guideline that we need the supplement under some special circumstances or context-specific recommendation. For example, like regarding the children 6 to 59 months and pregnant lactating women under the emergency, or at the COVID pandemic, if the access to the nutritious food is not enough, we need to use this one. Another context is rigorous research of the pregnant woman indicate WHO antenatal care recommendation. So including clinical research. So we need more research, but for example, implementation research when programs are assessing the impact of switching from iron and folic acid supplements to macronutrient supplement still is relevant. But today we heard lots of evidence and positive impact of the MMS. So first, as we discussed, WHO included the MMS to the essential medical list to support the availability for research, and we need to supply. We need to discuss about improve supply, cost, and access. So let me conclude that one that we heard lots about the country context. So we need to discuss about cost effectiveness as well as equity and equal access to the MMS and education and to the people. And all services should be provided comprehensive manner. We should not put only one issue. Maternal child care should be come to the center of the PHC, primary health care and the health services, and that's comprehensive services provided. But finally, I should say that WHO is planning a technical consultation in 2022, the next year, to bring together partners to discuss the research that will contribute to the related WHO guideline. This will inform the recommendation of the use of the MMS, multiple macronutrient supplementation, as part of the routine antenatal care, and also formulation of the United Nations International Multiple Macronutrient Antenatal Preparation. So we're looking for the continued discussion. We need a voice from the countries and the researchers and the private sector and all partners, and we work together to reach the target, achieve the target of the sustainable development goal and our nutrition targets. So looking forward to continue to work with you. And thank you very much. Over to you.
Thank you very much, Dr. Yamamoto, for your inspiring call to action. And thank you for letting us know the next steps And I'm sure that all the stakeholders are ready to work with WHO so we move forward on this. I'd like to bring our discussion to a close. Our time is up. I just want to say one thing to end, that when you put women at the center, it touches the entire household. Put women at the center, everybody in the household benefits. On this note, I'd like to say thank you. Thank you for the opportunity to be your moderator. It's been great. It's been fantastic. And if you want to learn more, please contact us and we will provide you with the information. Great. Thank you all very much, my wonderful speakers and panelists. Very grateful. Happy to have you with us on this event. Thank you very much and have a nice day.